Hello, everybody. Welcome and kumusta. Thank you for joining me. This is How, your occupational therapist, and welcome to Occupational Therapy Conversations. And in this episode, I'd like us to have a conversation about Margaret Rood. Margaret Rood and her approach to treatment and intervention. Again, I've had about 215 episodes of OT Conversations now, and I can't remember whether I've had a talk or had a conversation about this. So might as well, let's have it again. Let's have this discussion because I think unconsciously this is at the back of our heads. A lot of people have little information or knowledge about this, and people have been forgetting that, for me personally anyway, this is one of the root theories and theorists that OTs and physical therapists have been using and utilizing. Margaret Rood this is a very beautiful one. She is an occupational therapist and a physiotherapist at the same time. And she developed a neurophysiological approach. And guess when? She has done it in 1940s and 1950s, and her work was very influential because she explored the questions that to this day it is still very relevant. And the question was this: can a carefully selected sensory input help a person produce more effective motor response? So that was the simple question. And the original approach was described in the publications, including neurophysiological reactions as a basis for physical therapy. Guess when? 1954. All right. And it was published also in the Neurophysiological Mechanisms Utilized in Treatment of Neuromuscular Dysfunction. Guess when? 1956. It's an old and almost a foundation information and knowledge upon which all of the theories nowadays are based on. So the approach was often taught as a collection of techniques such as brushing, icing, capping, slow stroking. Yeah, these are some of the treatment intervention, right? However, the techniques are not the central point of this approach. So the real principle is this, really: the use of sensory input strategically to prepare the nervous system for purposeful movement, and then practice that movement until it becomes a more available and reliable source during movement and in function. Okay. And yeah, so sensory input is very, very vital. It is very important. So the central idea is that the sensory input influences the motor output, and that the movement does not occur independently of sensation. Yeah, before the nervous system generates a motor response, it will receive and it will process information that comes from the skin, the muscles, the joints, the vestibular system, and the wider environment, right? I've had a recent teaching or tutorial, and I call it Waking Up the Somatic Nervous System in Critical Care, and how to awaken the somatic nervous system after prolonged condition and when a person is in critical care. And it's technically coming from this. One of the roots for this, it can't go anywhere else because it really comes down to this. So really, before any movement comes out, it will receive information from the skin, the muscle, vestibular system, and the wider environment, right? So Margaret Rood, she proposed that sensory receptors could be stimulated in different ways. You can either stimulate it, or you can inhibit these sensations or regulate it. So if you stimulate it, you will facilitate a motor response when the response is actually absent. So there is a certain tone in a lot of things like movement, muscles, cognition, attention, right? Anything less than what is functional is hypo, and what you want to do is provide that stimulation to make it normal. And if it is hyper, like the likes of spasticity, for example, rigidity, overstimulated vestibular reaction, for example, that people are guarded for those people who are falling, you would want to inhibit that so that the person will have that ability to engage. So these are the only two things: you stimulate or you inhibit or you regulate. So she considered that motor behavior could be influenced by the interaction of the somatic, the autonomic, and the psychological factors rather than merely as isolated by muscle strength. Yeah. So if you want to do just strengthening activities, yeah, you can do that, but the entire system has to work together. But if not, then there will be a lot of interplay between the autonomic nervous system, between the somatic nervous system, right? If you want to remember it, so really the short way to remember it is that there has to be an input, and this input will generate a response. And then this response in the body, once the person reacts to it, will demonstrate a purposeful activity. And then if you do it, there will be repetition, and then there would be learning of movement. So motor relearning. There are four main principles in this treatment approach. The principle one would be the use of sensory input will influence muscle tone and motor response. And this is often described historically as normalization of tone. So Margaret Rood came before Bobath. Okay? So remember these guys, yeah? Normalization of tone, Rood came in first. This is the root of Bobath. So therapists would select an appropriate stimuli or stimulus, and what they would do is that it will encourage the desired response. For example, if a patient with reduced activation, meaning they're not moving, they will need an altering or facilitatory stimulus before attempting to move. Or a patient with excessive muscle activity, this would have been high tone, this would have been spasticity, or rigidity. They will benefit from slow, sustained rhythmical input before attempting a controlled functional task. Again, foundation of sensory integration for pediatrics, it's there. There are several sources of sensory information. The first source would have been the light touch or cutaneous or exteroceptive receptors, which you stimulate this through touch, brushing, stroking, temperature. What you're tapping onto would be the protopathic sensory subsystem. The three primary ones, pain, temperature, and light touch, they all go together and they follow the anterior pathway or the anterolateral spinothalamic tract. So that's one. Another source of sensory input that we can tap would be the proprioceptive input. And they would be stretch, resistance, pressure, weight bearing, joint compression. Why are these things separate? Because if you follow it, they will go into the posterior column of the spinal cord, and it will integrate one way or another to the cerebellum, and then it will have some connections to the cortex as well. So proprioceptive input is one. Another one would be the vestibular input. So this would be where you move the head, where you would stimulate the person using the entire body, rocking movement, rolling, because the stimuli or the sensors would be the inner ear. And that would be, again, a foundation of sensory integration for pediatrics. And it just works. It's just is. The other path would be special sensory senses, like for example, the visual sense, the auditory, the olfactory, and they have shorter pathways, but you can use these sensory subsystems to tap the brain and to stimulate the brain. Once the brain is stimulated and they know what they needed to do, then you will, or the person will generate a better purposeful response. In the normal world nowadays, the phrase normalizing tone should actually be used cautiously. Also, a lot of people have been using it. Tone is not a simple switch that you can actually turn off and on. People are focusing on tone, on spasticity, teaching about this. It's been going on for decades, generations upon generations of therapists from the 80s and the 90s and the 2000 up to this date. Tone is still a period where people have been talking about it. It's not a simple switch that you can just turn on and off. A sensory technique would produce a temporary response, but the important question is whether it improve a person's ability to perform meaningful tasks. And it will, but it has to be done for a long period of time. It will, but it has to be done with many repetitions. And again, this is the foundation where intensity comes in. You have to provide more and more and more stimuli. Yeah. So one stimulation, it will stimulate it once. You have to stimulate it, make the person respond, and then you do it over and over and over again. 3, 4, 5 minutes, 15 minutes, 20 minutes of session, it won't cut it. 20 minutes, 30 minutes is just the preparation. Yeah. So that's what's been happening in my observation anyway. If you want, you can prove me wrong, do your studies, investigate that, prove me wrong, then you'll have your PhD. So, second principle would be motor control develops progressively. So Rood believed that motor control is developed through a sequence from relatively basic movement patterns towards an increasingly complex skilled function. And that's why this is where the foundation called its ontogenetic developmental sequence. That's why it's called NDT, mental treatment, because the study was an observation of children from birth to infants, where at first the child would be influenced so much by the reflexes, massive flexor tone, high tone on flexion, bold up position. And then little by little, the person will start having the head controlled. The head starts to move, and then they crawl, and then there is segmental rolling, and there's leaning on the elbow. And then there is now the trunk will stimulate, and then there will be quadruped, crawling, isolated movement, all the way to kneeling and sitting and standing. So there you go. It develops progressively, right? And the classic sequence, like I said, is supine withdrawal. There would be rolling, prone, extension, neck is co-contracting. Like I said, the neck extension. After the neck co-contraction, you have prone on elbows, quadruped, standing, and walking. And the underlying principle is more important than memorizing the postures. So the principle would be this: person may need sufficient postural control and proximal stability before they can use their limbs effectively for skilled activity. And that's true. You can have the limb, it's okay. You can just do it lying down, especially for adults, because they've already developed that skill. So they won't lose that unless there's neurological problem. But for a neurological insult, like a brain, head injury, spinal cord injury, it follows that pattern. So that's why this approach is more with anything that will have an effect on neurological conditions. So any conditions that has that's what you would be using. Like I said, so another example, say a patient may struggle to use the spoon or they may have difficulty washing their face, they will have difficulty with personal device care because the trunk stability is not there. Shoulder control, head control, these are all very important things. And the therapist will have to address these before thinking about improving those skills. Application, critical care, somatic nervous system impaired, somatic, the muscles, everything is all weak. And what's the first treatment that we do? We sit them out, okay? All the way, and then the person is slumped, there is no movement. You'd put the arms on the one side, but it's not being stimulated enough. What's happening to the head? You know, the head is bent down. The person needed to control that head to begin with, right? So just remember, there are some limitations though. The modern motor control science does not support treating this in this sequence anymore. They don't see it now as a rigid ladder as compared to how it was years ago, and that the patient must be able to follow, like roll and then supine. The human movement is shaped by, now there is an influence of cognition, of perception, of context. Yeah. In fact, in 2018, a review concluded that fixed developmental sequence element is one of the weaker aspects of this theory. Yeah. But you don't have to do it. You don't have to have that treatment of lying to sitting and standing, because that would have been for a cerebral palsy case. Yes, because the child has not developed those skills yet. So you need to get the child to experience all of this. But for somebody like a grown-up who's had a stroke or a head injury, I personally, I still feel that it helps. It really is, because I've seen it so many times. I've applied it so many times. But for somebody with a normal, like the brain, the muscles, and the nerves are connected to one another, you don't have to follow that sequence of lying, prone, to quadruped, to standing. But the treatment approach would be work on the head control, work on the trunk control, yeah, one way or another, because it will really help. Okay, and the third principle would be that movement should be at some point become purposeful. That's the main objective. So Rood did not intend the sensory stimulation to remain isolated in practice. And the desired outcome really is to have a purposeful response. So all of these sensory stimulation in the continuum of rehabilitation, these of like continuum being adjunctive therapy, enabling therapy, purposeful activity, and then discharge planning, this would fall on the adjunctive activities to stimulate. After you've stimulated the muscles, you get the person to do little things, and that would have been enabling activity. And then after the enabling activity, you do the purposeful activity. So your session, if you follow that alone, can almost be like the entire morning for one patient. Yeah. So this is really important for an OT. Just remember, guys, the target would be for us to get our patients to do something functional. But you have to look at the context as well. If people are in critical care, you can't do these things, but definitely you can stimulate the body, the adjunctive therapies. So in my program in critical care, I call this the performance component restorative program. It would fit on the adjunctive therapy program. And yes, okay, so that it would roll on that one. And what's another principle? Repetition is required for motor learning, right? So the belief, a brief stimulus response. So if you have a stimulus response, it will help produce a movement. It will stimulate it good. But then it will not generate a lasting functional recovery. And what's happening? What am I observing? People will do it. There's more of a teaching, more of a yap from a therapist, and they will start teaching. It's like, you need to do this, and the patient can't move. I know I need to do it, but I can't move it. Yeah. And then the therapist will, come on, you can do it. You're gonna. I know I can do it. You have to do something. You need to touch the body. You need to stimulate and awaken those sensory input, right? So it needs to be done over and over again. So the response has to be repeated so that a meaningful activity will take place. And once you follow that, again, it will eat up time on your session. Proper rehabilitation. The challenge is the context. Where do you do your rehabilitation? If you're in an acute hospital, you can't do that. It has to be done in the rehab facility. But not a lot of people stay in the rehab facility now. They are sent home as early as possible. Then that is where the therapy needs to happen. So it is a challenge for the community teams to do the session out in the community. Dun, dun, dun. And there is a gap because the service is reliant on the government paying the workforce. Yeah. Whereas if you can be asked by another person or another, like a patient, for example, they ask, can you help me? All these throughout, then yeah, it can be done. There are 4 levels of motor control in this theory. The first one would be the reciprocal innervation or the actual mobility. So the reciprocal meaning the agonist will contract and the antagonist relaxes. So an example, simple elbow flexion, that's one. Okay, reciprocal innervation. While one side is moving, the other one is relaxing. Yes, reciprocal innervation. Then so movement, and you can see that in a child, it's like imagine an infant, it's like moving around. The next thing would be co-contraction or stability, where the agonist and the antagonist muscles work together to hold the position. So if you sit up, that sitting forward, that is the reciprocal innervation. You only have the flexors sorting out are active and the extensors are relaxed. But once a person is sat up, then the person will need to actually have that co-contraction between the flexors and the extensors of the back. And that's what people would say core stability, right? Same thing when a person is leaning forward or leaning on their arms or standing, that's co-contraction. The next thing would be heavy work, where there would be mobility superimposed on stability. So this is when the person maintains a stable base while producing movement against resistance or a load. When you're pushing on something, when you are crawling. Yeah, so there is big movement and yet you are still stable. So imagine a critical care patient moving, sitting down. That's where you are, the co-contraction. But then the next thing is now you're sitting up. Now you start to do something. So this is mobility superimposed on stability. And then the last movement would be the skilled or controlled distal movement on a stable base. And this is where dexterity comes in. Okay, these are the 4 stages. Remember, guys, it's so nice to try and to be able to remember these things. And it's just at the back of my head at the time and at the moment. So it's good to be sharing it so you can learn about these things. So if you want the sequence about this, here it is. Move, hold, work, and then perform it skillfully. Right? Roll, okay? Lean, sit down, hold, okay? And then work, start to move the upper limb. Or, if you're sitting down, then skill. And again, that's distance. The distal part should be okay. Be moving around. Look at me. I'm moving my hand. And then the stability has to happen, right? Okay. So some of the techniques. When we're talking about Rood, you have facilitatory techniques and inhibitory techniques on how you stimulate. Facilitatory meaning you stimulate the muscles. Facilitatory would be quick brushing. And you have, this is alerting, so facilitatory. And what you do is you're preparing the extensor surface of the forearm before reaching the task. Brushing. Back in the days, 40s, 50s, 60s, 70s, there is a brush which is a therapeutic one where you press a button and it spins. And even the rotation has been studied, how fast these brushing, but it really does work. But nowadays, not a lot of people are using that. Icing, again, it's a brief thermal stimulation and it will attempt to facilitate a weak or a muscle response. You do the ice, it tenses up a bit. right? Because there are sensors into these icing. It can do it for swallowing, if you put it there. There's been lots of studies about it, but it's just being forgotten about it. Light touch or tapping. Again, tapping, you tap the muscle belly while asking the patient to initiate the movement. Stimulate, stimulate, stimulate. Quick stretch is the best way on how to facilitate movement after a stroke when nothing else is there. Quick stretch. So you are facilitating that deep tendon reflex first. Vibratory input is another one. It's a proprioceptive stimuli, and it will encourage activated of whatever is being vibrated. Resistance is another one where a graded resistance will be used. You can use that during functional movement. What else? Weight bearing or joint compression. That's why it's weight bearing. It is weight bearing or heavy joint compression. By definition, it has to be a compression that is heavier than the body weight, right? And then the last one would be a faster vestibular input, and this has an alerting effect. And that person would have controlled movement, and where an increased arousal is definitely suitable and appropriate for this one. Okay. What else? Inhibitory techniques. So some of the sensory techniques. Slow rocking. So you're using the vestibular stimulation. If they're high tone, this is more, and that's why you would do this in a mat exercise. You'd be in the mat, you'd be holding the person in a bold position, and then you do slow rocking. Okay, rhythmic stroking, neutral warmth, prolonged stretch, sustained stretch. That's why when you do the weight bearing, it is an inhibitory response. Sustained pressure and slow rhythmical movement, like I said, right? Now, how do we want to apply this? This is restorative, okay? It's a restorative intervention. You need to do it. You start with the activity first. Find out what you want to do, and then find out, once you see the person, are you moving? Are you not moving? What are we going to do? So we want to get you out of bed. Can you roll? You can't roll. So you analyze the motor barrier. What's the reason? Is it because the arousal is reduced? Is there a poor initiation? So that's all the will, right? You got to stimulate. Is it because of the weakness? Is the excessive muscle activity? Is it recessive or less of the muscle activity? Is there reduced postural control? Is it fatigue? Is it pain? So analyze these things. Once you know what the problem is, then you can provide the appropriate sensory input for this, and you can actually have a clear rationale why you do what you do, right? So the patient, for example, patient has difficulty initiating active elbow flexion. So I will then, as a therapist, I will use a brief tactile proprioceptive input immediately before the active movement is attempted. Yeah. So when you do that, you're explaining your reasoning, and you should know your reasoning. You should know your anatomy, physiology, kinesiology, pathology. Yeah, you are everything apart from a doctor. So anything that involves the body, the movement, you should know that. If you're in the physical dysfunction, physical therapist, yes, they should know that. Then factor in the cognition again, which is, again, a different story. So after that, once you've stimulated the person, you know what the problems, you've provided the input now. Now you can incorporate the response into purposeful activity if they can do it. If they can't do it yet, then just stay. Get that movement going. Stimulate. Yeah, before you do that co-contraction phase. After the co-contraction is heavy movement and skilled movement. Okay? And then repeat, grade, and assess. Okay? So what you want to do is you want to be able to remove that stimuli that you're providing from your side, and you want the patient to actually just do it themselves so that it is self-directed, right? Okay, so let's have another example. Stroke, for example. Okay, so the patient has reduced awareness. Here's the case. A patient has reduced awareness in the activation of the arm, and they are unable to bring the toothbrush towards their mouth. So that's long-term. They're in critical care, right? So that's a problem. So what you want to do is you want to position the patient first, sit them out, and stimulate with the adequate trunk support, okay? And then you would stimulate so the patient would have an awareness of that arm. How would you want tactile input is what you would use to stimulate that. And then you can do supported weight bearing to stimulate that proximal stability. And then to start with, once you've stimulated, then you can do that active assist towards reaching that toothbrush. This is all functional now, right? And then you can have repeated practice. Let's do it again, do it again, do it again. If ADL retraining is very difficult to do because it's only just a short period of time, do that enabling activities where you would simulate all of that movement until you can transfer that into an ADL retraining. And then you integrate it then with the patient's oral routine, oral care routine. Okay, so sensory input is only the preparation. Like I said, it is the adjunctive therapies. Okay, and then the outcome is improved. The objective would be the oral hygiene. And that's the one that will be the outcome that you want to measure. Okay, another example, critical care. Okay, what's happening? Say a patient is recovering from prolonged critical illness. So they are awake, for example, but they are engaging, but in a very minimal way. Why? Because they probably have reduced initiation, generalized weakness, there's limited tolerance of the activity. So with Rood's approach, you would establish the level of arousal first. Okay, but you have to make sure that medical stability or medicine is allowing that to happen. If they're on sedation, it's a trick, it's not going to work. That's why when I come to critical care and the person is asleep, my first question is, are they on sedation? And if they say not, the nurse would say to me, no, they're not. Then therefore, the objective is to arouse this person or to stimulate this person to get them off that, to start having purposeful responses. So how do you do that? You want to use familiar voice, orientation. You can use tactile stimulation so the person will attend to it. You can have facilitatory active assist upper limb movement, quick stretches, because the more the person will feel the body, you'll actually, stimulate the mind. It's almost a more primitive ways when you're waking somebody up. What do? Hey, wake up. And if they don't wake up, you shake them, right? And that's how it is. And then you can start introducing some tasks like, for example, introducing a flannel and water. And this is now my program, which I call the matter sensory approach in critical care. Watch the space for that, guys. So today and nowadays, what remains useful of this model? The theoretical model is technically not, is there. It is the foundation. The things that we need to break away from is that the hierarchical model, where it's developmental. But the stimulation, that stays. Yeah? Some of the principles really stayed into this day with Margaret Rood's sensory stimulation, for one. It affects the motor output. That stays. When you're normalizing the tone, yeah, again, that is part of it. That's today. With regards to following developmental principle, which meant you should consider the postural control and the graded task appropriately. Meaning, if a person, you're doing sitting sessions and the person is not managing it, if the person can't manage rolling in bed, then start doing that rolling first. At least there's gravity eliminated. You just want to activate those muscles. All right? That's what that is meant by that. Using of purposeful activity, that still remains, and then you just have to repeat the response. Okay. What's happening? 2025 Cochrane Review. It concluded that physical rehabilitation can improve function of, after the stroke, but the neurophysiological approaches are no longer the superior. It's not superior to other approaches. And others are saying that it's probably less effective. You know why? Because I think people don't know how to do it. Yeah. And people have not been investigating it anymore, or, it's all education. I doubt, the skills of the people nowadays on how to use these sensory motor approaches. Yeah. So really nowadays, Rood, informed. Yeah, so Rood informed sensory techniques, the principles is what should be respected. Yeah, it's still clinically reasoned as preparatory tools. It's a very good treatment intervention, particularly with adjunctive therapies. Okay, when you're doing this approach, obviously you need to be touching the body. There are things that you need to keep an eye on and watch out for. Skin integrity, for one. Altered sensation, pain, autonomic instability. Yeah, then autonomic instability, heart, lungs, autonomic dysreflexia. You would do that. Cognitive states, whether they're distressed or they're agitated. If they're delirious, maybe you can use the calming effect. See, I can't even work my way around it using this technique, right? You don't do a lot of things stimulatory or facilitatory when somebody is delirious. You need to just go use the low voice. You need the slow stroking. You need to do a deep pressure. You need to have calming scents rather than citrus based. So there's ways around it. Fatigue is one, but then again, that's biomechanical frame of reference, but watch out for fatigue. But if they're passive, it should not be a concern. Fracture risk. If there is a risk and you have to move the upper limb, then yes, obviously that's a problem. Look at the vascular compromise, lines, attachments, medical devices, and the person's consent and their tolerance as well. So critical care, the intervention is also, or you just need to be consistent with local safety guidance in critical care and their physiological status. So if you want to remember it, a simple memory aid would be Rood. Remember to regulate the motor response. Organize the movement progressively. Occupation gives the movement a purpose and dose through repetition. So that's very good, right? Whether you remember it or not, it'd be good because I haven't remembered that for a long time. All I know are the principles and then I can do it. Okay. So the essence of this approach, guys, is not about brushing, tapping, or icing. What it is the disciplined use of sensory input to make purposeful action more achievable. Okay. There you go. So this is a relevant information involving occupational therapy. If you liked this, do us a favor, share, subscribe, things that I have to say because people are saying that. But really, it's just here, available for you to listen to. If you like it, talk to your friends about it over a cup of tea, learn together, grow together. And just remember, anything you do matters and has an outcome. Until next time, bye!